European Public Health Alliance, and I will be moderating the session today. I don't think the topic needs further introduction. If you're here, it's because you understand the importance of health data and evidence-based policy making. So I will not take too long for this introduction. We want to share a couple of housekeeping messages before we start. So the session is going to be recorded, and it will be available online in a few days. So if you miss part of it or want to rewatch, that's not a problem. And then to keep the flow of the conversation, we will only be addressing questions towards the end of the webinar. So we will do it in a way that we will have four speakers presenting at the beginning. We will have a short Q&A session for those four presentations, and then we will have a fifth final session, and then another Q&A session. So we have here today four speakers. We have Miriam Sasso from Sciensano. We have Mirana Turk, I hope I pronounced your name correctly, from the European Patient Forum. We have Inés Nieto from the University King Juan Carlos of Spain. And we also have Laura Berthold from UNIA. So as I said, I don't want to take more time for myself. I will let them present, and I hope you enjoy the webinar. So we will start our presentation with Miriam Sasso. Miriam, do you want to go ahead and share your screen?
Yes, thank you so much, Jaisamel. Let me just share my screen. Let me know, of course, if you see it correctly. I'll put it in full screen. It's just a little slow, but it should come any moment soon, I hope.
I do personally see it.
Okay, so if it's okay, then I should be able to start. Let me know if when I go to the next slide, it doesn't change for you, but it should be all okay. So first of all, welcome everyone, and I'm so happy that I can open this webinar. Today we'll be talking about the relevance of moving from data to evidence-based policy making, so from data to public health action. Today I would like to open with telling you a little bit more about health information systems, some key differences across Europe, and how relevant it is to really have an overview of how the health information system work and how and where we can improve them. So first of all, I would like to provide you with a little bit of an overview of what a health information system is, because basically health information systems are the basis for the generation of knowledge for improving the health and the well-being of the population. So basically, we really want strong and well-functioning systems to be able to have a good understanding of how we can improve the population health. A system is something really complex, and basically it's the whole process that goes from collecting to process to reporting, from data to information to knowledge, that then help us to support decision-making process, but also help us to generate new knowledge and also to guide the population towards more healthy behaviors. If you look at the diagram that we have here on the slides, you can see that a health information system starts with the collection of data. However, basically, data alone doesn't have a lot of value until it gets analyzed. So basically, until multiple sources of data gets combined, and then we create information. So we analyze the data to understand what are, for example, the different trends. But then to really transform information into knowledge, we need interpretation. So we need to expert that comes together, they bring all these data sources together that have created report to really understand how this data can be used. And finally, we go towards wisdom, when this knowledge that has been brought together by different experts really gets used to basically making policies and go to from data to public health action. However, what is really important is also that on the side of this pyramid, there needs to be some fundamental building blocks. So we need to have the people that can run the whole health information system. We need to have the right legal infrastructure. So basically, we need to have policy in place that supports the well-functioning of our health information systems, but also we need to have the political settings that allow us to improve health information systems. In Europe, what we see at the moment, but also since the origin of health information system, is a lot of differences across countries. This is normal because each country has different social culture specifications that basically brought to the formation of different health information system. With the recent crisis of COVID-19, we could see that those differences, so both in advancement for just how a system is created, have been like the difference has also increased. And in one way, we could see that some countries really invest in innovation, so to strengthen some part of the health information system. But from other countries, we saw that some of the bottlenecks, or basically some of the issues that those health information experiences were exacerbated. So basically, they became worse than before. What we do in our team, in the team called Innovation Health Information Systems within Cienzano, is that we really try to assess different part of the health information systems, depending on the topic at hand, to basically gather first an overview. So what is the state of place of a health information system, a part of the health information system? You can always narrow it down to a specific topic. So first of all, what is in place? Then we want to understand what are the things that are really working well and what are things that needs to be improved. So for the things that are really working well, this is great because basically other countries can learn from these best practices and try to implement in their own system. So they really, you can see some innovation that can be translated in other system, of course, with the needed adaptation, because as we said, every system is different, but it really can bring like innovation in other countries. At the same time, identifying weaknesses, it's maybe even more important because weaknesses or like bottlenecks basically are points where the system is sensitive, so it's more delicate, let's say. So when, for example, a crisis state or like more like a bigger flow of data comes in, then this is where the system could really in a way collapse and brought bigger problems that will be harder to solve. So it's really important to be able to identify those weaknesses, also because those can bring to like the creation of a plan on how to improve them. So basically when we do this assessment and we identify the strengths and weaknesses, then we can interact with all the stakeholders part of the systems to really understand how we can bring a change and what are the priorities. So basically, what do we need to start with strengthening? And this, as you can imagine, can really help with preparedness because as we'll see in a moment with some COVID-19 examples, some part of the systems were not prepared for the COVID-19 pandemic and then brought some real issues. So here, I just want to show you the methodologies that we use that gets adapted from project to project, from topic to topic to perform a health information system assessment. Basically, after a topic has been chosen, so the focus of the specific health information system assessment, there is always a preparatory work. So first, we want to know what is out there already. So we want to see what are previous assessments that have been performed, what are evaluation. We can perform a systematic literature review to really see what is all the knowledge available for that specific country or this specific, like multiple countries, if we're assessing multiple countries, to understand what is already known about this. When we also do this process, we already start to see what are part of the system where we know less about. So we really want to talk to the stakeholders that are responsible for those to be able to gather more information on it. So in the second part, we perform, like after we have selected the stakeholders, we perform interviews. Basically, we use an adapted version of the WHO tool that is called Support Tool to Strengthen Health Information Systems. That is basically a list of questions divided by domain and part of a health information systems that we use as a starting point. But then we adapt to be able to really map or to really assess a specific part of the systems that we are interested in. But also we adapt the question depending from stakeholder to stakeholder because it's not what we want to ask. We want to have specific questions for the expertise of the stakeholder that's in so that we can really benefit from the expertise. So at the end, every assessment that we perform will have a different version of this assessment tool that is specific for that part of the system and that topic that we're interested in. So after all the interviews have been performed, and those are done separately, so one stakeholder at a time, unless they're from the same team, then we bring all these stakeholders together so that they get to know each other and they also see an initial overview of the report and the analysis that we have performed on all the information gathered. This is really a great opportunity. If it's in person, it's even better because then people can get to know each other, but of course it depends from the time and availabilities of the different stakeholders. And basically we present them the initial funding. So did we understood everything correctly during the interviews? Maybe there is some additional information that they want to share, but also what is really important is they get to know different parts that are relevant for them as part of the health information system. you see how this becomes more and more relevant also when we talk, for example, about One Health. If we go for a broader topic, that before we was always human health, animal health, and environmental health, but we want all these these stakeholders to know more about each other, to really be able to collaborate. After that, basically the report gets finalized, all the feedback gets taken, so we update the report, and depending from the project or from the wish of the country that has involved us in these activities, we produce different outcomes. It can be like 1 pages, very short overview. It can be long report, really where you see almost all the information gathered during the interviews, but it can also be scientific publication or presentation, basically like this one, but with a focus on the results. We have done this in multiple times, but with a different focus every time. So the first project that I want to briefly tell you more about, it's called FARA, the Population Health Information Research Infrastructure. What we wanted to know with this assessment is the COVID-19 health information system. So basically, what was in place and what had to be implemented in order to accommodate for the COVID-19 pandemic. Because what we saw is that at the start of the crisis, not all the health information system, or we could say very few, were ready for such a crisis, and some parts were really affected by the crisis because, for example, they didn't have the capacity from one day to another to be able to collect the amount of data that was needed to monitor the crisis. So we did this assessment in 8 different countries, and we also have a nice publication about it. But today, I just want to provide you with an example of some of the identified barriers, but we also have best practices, of course. So today, I think I could pick under organizational data gaps. Basically, what we saw was that in certain countries, there wasn't a legal mandate for the private sector to share systematically data with the public health sector. And this, for example, in the case of testing, was a very big issue because the testing would be done both from private facilities and public facilities, but then the counting of the testing could be done only on the testing done by the public facilities. And you can see how this does not provide you a real overview of what is the situation in the country, because you don't have an overview of, for example, also the negative tests that were performed, because only the positive one had to be implemented. So this brought basically then a discussion within the country that had these issues on how to update that in their pandemic preparedness plans, because each country could use this assessment to basically bring ideas on things that they needed to implement to do better in their pandemic preparedness plans. The second project that I want to introduce you to, it's TEDAS. Basically, the assessment that we have performed in TEDAS, that stands for Towards the European Health Data Space, focus on a really hot topic right now, which is the implementation of the new regulation, the European Health Data Space. Basically, here we really wanted to know, besides the technical system, that the technical data management systems that the country had in place, what was the willingness of the countries to join the European Health Data Space. And these assessments were performed on 12 different countries. Also here, to provide you with a taste of some of the fundings, a nice publication will be coming out any moment, I believe. Here, for example, we can see in the bottom of the slides, all the countries that we investigated had the political will to join the European Health Data Space. However, if we look more at the technical indicators, so the second one about having a common metadata catalog, we see that only 5 out of 12 had this in place. And basically having a metadata catalog, which is information about all the data sources present in a country, is something essential for the European Health Data Space, because basically it wants to allow researchers in everywhere in Europe to be able to find the data that they need. So this assessment just provides them with a clear overview on what they had to prioritize and work really as soon as possible to be able to be prepared for the coming of the European Health Data Space. Finally, a third project that I would like to introduce you is the EU HIP. So this one stands for EU Interoperability with the HERA IT platform. And this is really collaborative work with HERA, because basically HERA, which is the Health Emergency Preparedness and Response Authority of the European Commissions, what it wants to do is that they want to establish a new platform that is called Athena, they will collect data from the different member states. However, the topics that HERA focus on, it's really broad. So in this assessment, we provide more of an overview of what are the different IT systems and the digital infrastructures and the relevant legislation, for example, for sharing data one day with HERA via this Athena platform on multiple topics. So pathogens with high pandemic potential, antimicrobial resistance, CBRN, which stands for chemical, biological, radiological, and nuclear threats. But most importantly, because it's really the topic where HERA has the most knowledge, the medical countermeasures needed for all of these different countries. Here I have put a slides, as I will be sharing those with you, where you can just scan the QR code later on and just gather more, read more information about it. So depending from the project, we have created a detailed manual on how we perform these assessments, but we will also find additional materials so about the results and the publication that we have from this project. Finally, before I give the floors to my colleagues, there is one last project that we have started recently, but that I still think that would be extremely relevant for you, because it really focused from the exchange from researchers to policymakers to do evidence-based policymaking. And this is the Belgian project called Belgian Pandemic Intelligence Network. So here we want to investigate how, in time of crisis, the exchange of knowledge from researchers to policymakers should happen. So what we did is that we have done a systematic literature review to really understand how it took place during COVID. So we wanted to see what were all the different advisory boards that were in place, how was exchange of information happening, what were also here the strength and the weakness of the system. For example, just to give you a taste of some of the results, we saw that when we talk about legal and explicit mandate, it was really hard to understand, depending on different advisory board, what was the precise legal mandate and what they were allowed or what they should have been providing advice. So sometimes what happened was that multiple researchers were providing advice on different topics, but not in a systematic manner. And this provided a lot of confusion and also a lot of the double work. Finally, I just want to conclude with slides to just let you know that we are always working towards strengthening health information systems, and we are more than happy to continue to do this with other colleagues. We are involved in multiple projects, so the EU HIP and so the one in collaboration with HERA, the one of BPIN are still ongoing, but we are always interested in learning more about health information systems for informing the countries and the European Commission on what they should focus to strengthen different part of the systems. So if you're interested in continuing or starting to work on this topic to learn more and how to do it, feel free to reach out. In the last slides, I will put my contact information, and then I'll share the slides with Jaisalmer so that she will be able to share with all of you. So for the rest, thank you so much for your time, and I look forward to your question.
Thank you very much, Miriam. And yes, of course, we would be happy to share the slides with all the participants if you are okay with it.
Definitely.
As we said before, we will be taking questions towards the end. Thank you from your perspective working for a public health institute. Now we move to another initiative that I also hope that our audience finds inspiring. In this case, it comes from a civil society organization, and it's going to be presented by Milana Turk from the European Patient Forum. So Milana, please go ahead.
Introduction. My name is Milana Trokla, and I'm the Data Saves Lives Coordinator, and I work as Policy Officer at the European Patients Forum. So moving on what's actually Data Saves Lives, this is a multi-stakeholder initiative that is led by the European Patients Forum, so organization I work for. And EPF is an umbrella organization active at the EU level, and our members are both EU disease-specific big organizations or national coalitions of patients. And the aim of the Data Saves Lives initiative is to raise wider patient and public awareness about the importance of health data. It's about improving the understanding of how data is used, but also to establish a trusted environment for dialogue on any digital health and data issues. Why did we need to feel to create an initiative like this? Well, first of all, it's because we really believe that to truly harness the power of health data, it needs to be shared and used, but effectively and responsibly. And I'm going to later on also explain what we mean when we talk about responsible use of data from the patient perspective. And also because we believe that scaling up the use of health data has great potential to improve the quality of healthcare and accelerate health research. However, we also know that there is an acknowledged gap in patient and public awareness about the importance of health data use and be used, and there is an even bigger gap in understanding how this data is actually being used. And another, issue that we see is that there was not any trusted multi-stakeholder environment for this dialogue about responsible use and the sharing of good practices that was institutionalized. So we believe that creating an initiative like this would provide a basis for such a dialogue in such an environment. So I mentioned the responsible use of health data. And so before I go more into the Data Saves Lives initiative, I just wanted to briefly touch upon on what we actually mean by this. We know that the use, so for both primary and secondary use, so both reuse and reuse of health data have the potential to improve the well-being of citizens. It has the potential to make our healthcare systems more effective, data-driven, and easier to use. It can speed up scientific research and make healthcare services more sustainable and affordable for all EU citizens. However, for these to happen, the use and reuse of this data must be responsible. And by this, we mean respect for do no harm principle, the protection of patient privacy and confidentiality, building of trust in the healthcare system among the public, ensuring transparency, respecting the ethical, legal use of sensitive medical information, but also empowering and engaging patients, and utilize this data to improve outcomes for the patients. So above, where I kind of just say what we see as which potential the use of health data has, it's quite general. But when we go a bit more into what actually it means for patients, it could mean advancing the understanding of diseases. It can lead to more personalized healthcare and more accurate diagnosis, and it can also lead to new and quicker medicines and devices, and I would also add cheaper medicines and devices. And all of this would then lead to enhancing the quality, safety, and sustainability of care, and potentially transform this healthcare into more participatory process, because the public and the patients and the citizens are actually more involved and more informed about the responsible use of data. So how does data saves lives, and how do we get people talking about health data? One of the, I would say, the biggest successes of our initiative are the bootcamp trainings events. So these are events that take either 1 or 2 days long. And on each bootcamp training event, we discussed different topics. So some of the examples are our very first Data Saves Lives training bootcamp that took place in October 2022. And so it was 2 days long, and we had 17 regional and national level organization representatives. And the topic of this training was the basics of health data terminology, but also latest EU legislation on health data. And then we also explored the key challenges and questions that these patients groups had when it comes to building confidence and knowledge in this area. The second bootcamp took place in March 2023. And this time it was fully focused on artificial intelligence. It was again 2 days long. And we as a group explored the basic principles, the terminology, the governance, and the legislation on AI, both in the EU, but also internationally, to discuss then in the end working examples. And we also had interactive workshops, serious games with which we played. all in with the aim to equip the patient organizations with the basic knowledge on AI. Our third bootcamp took place in Brussels last year in December, and this time we wanted to make it even more hands-on. So we wanted to explore what patient organizations themselves can do with health data. So this time, what we did was to create a workshop on establishing community-led patient registries, so disease registries, patient registries, with the aim to empower the participants with insights in how this can be done, and also how patient groups can actually shape these registries for community benefit. And lastly, we also had this year another little bootcamp, and this one was done in collaboration with the European funded project H2O and with the Health Observatory Austria. And we try to explore innovative approaches to improving patient outcomes while prioritizing data security and privacy. Another thing that we do to make sure that we raise this awareness and that the knowledge about data is shared is by creating these toolkits. So each training, bootcamp training, had also, as a result, one big toolkit around 20-25 pages on the topic of the training. So the first one was about health data, how to understand and communicate about the power of health data. The second one was on AI, and the third one was on data registries. So as you can see, we start from doing these workshops with the trainers, with the people who actually know how to explain this thing in lay language, and then we also translate them into something that can remain and can be translated, and it is indeed translated into several languages and then shared with the wider public. And then one last slide on what we're actually expecting from Data Saves Lives in the future and what we are doing. So in November 26th, 27th, we are having our 5th anniversary because Data Saves Lives was launched in 2019. And this event is going to be a 2-day-long event where we're going to discuss issues such as European health data space, AI, HTA, and digital-related technologies. We're going to discuss data protection. So everything that's really related to data will be discussed here, and our main audience will be patient representatives, but also many, many other stakeholders. Another thing that we are doing as a, to stay up with the pace of what's happening at the EU level is to create something for the European health data space. So in this case, we're doing a toolkit for patients and patient organizations in which we explain what the European health data space is. We explain what can be the potential benefits and potential, obligations that both healthcare professionals, patient organizations can have resulting from the EHDS. And our aim is really to improve people's digital health literacy and make sure that people understand what's actually coming with this new toolkit, with this new legislation. So this toolkit will be, of course, free of charge in lay language. It will be translated in several EU languages. It will be adaptable to national, regional contexts. This means, for example, that while maybe in the English version we referred simply to electronic health records, when it's adapted to national regional context, we can actually add the name of the electronic health record of that country, or we can also add any specific rules that the national, that the member states will actually decide to bring upon when it comes to EHDS, because member states will be able to decide on many things. And it will also be expandable, which means that we're working also with other civil society organizations to make sure that this is expandable also to healthcare professionals, community pharmacists, etc. And that was it about the Data Saves Lives. If you have any questions, I hope we have some time now, but also feel free to get in touch. And if you would like to collaborate on an initiative like this, we would be very happy to welcome you. Thank you very much.
Thank you very much, Milena. We are very excited to see all the progress that you're making, and we're especially interested in that toolkit that you just explained. So we will be having a few minutes for questions towards the end. Now we're moving to another civil society organization. We have Laura Berthoud here today, who is going to bring the equity perspective into health data collection. So Laura, please, the stage is yours.
Yes, hi everyone. I'll also share my screen. And you should see two screens next to each other. Is that the case? All right, perfect. So today I will talk about the Equality Data Hub that we created recently at UNIA. And the goal of that hub is to find data on discrimination and inequality in Belgium. But first, I'll talk a little bit about UNIA itself. So I work at UNIA, and it's an independent public institution in Belgium, which promotes equality and combats discrimination. And it has 4 big missions. The first one is the one that we're the most known for, and it's protection. And this is for people that are discriminated against that can report this with UNIA, and then we will provide support to them and mediate with the potentially discriminating organization and eventually move to lawsuits if that's necessary. We also do policy work where we try to influence political decisions in order to create more equality and anti-discrimination. We provide training and workshops on inclusion to companies and organizations that want to work on this issue within their personnel. And then finally, we also do research to understand inequality and discrimination better. And I am part of that last team, so the research team. As I said, today we're going to talk about the Equality Data Hub, and that's also what you have right on the left of your screen here. The tool doesn't exist in English, so I'll go through it in English with you, and you'll see the tool in French. It also exists in Dutch. So the Equality Data Hub was created because, of course, there's always a need to have a clear picture of an issue that you're trying to combat in order to make the work useful. And so that's also the case when we talk about inequality. So we want to have a clear picture of what we're dealing with. And actually, a lot of research has already been done, both by academics as a lot also by NGOs and just civil organizations. But it's often hard to find this information because it's just kind of dropped into the void of the internet, and it's hard to find what you're looking for. And that's why we created this data hub. So it brings all data together, which is called equality data, which is any data that could inform you about discrimination, equality, or inequality, and in this case, in Belgium. The main goal of the tool is that policymakers and people that are trying to influence policy can develop policy that's based on evidence. That's just a slide for later if you want to look back at it. So I want to walk you through the tool and show you how it works. So my proposal would be to do this following a case. Let's say you need to write a policy proposal around health and healthcare for Roma and travelers in Belgium. You want to assess their current access to healthcare and understand the most important issues. So what you would do is you go to the Equality Data Hub and you scroll down, and then under criteria, you can choose the ground for ethnic origin, migration history, ancestry, other racial criteria. And then within the domains, you can choose health and well-being. Then under the keywords, you can choose Roma. And then let's say we only want English sources so that you can actually understand what it says. And then you just scroll down and you look for the source. And then you can go to that source. I opened it already, so it's all ready and up here. And based on that, you could find really useful information to create policy that is really based on real information that can inform the decisions that need to be made. So for example, in this source, one of the things that's talked about is the life expectancy at birth for Roma and travelers. And this is actually a number that I wasn't aware of and that kind of shocked me. Apparently, the life expectancy at birth for Roma is 70.1 years old for women and 64.6 years old for men. And you can see the disadvantages compared to the general population, which is pretty extreme. And then in terms of medical insurance, the coverage is quite high across most surveyed countries. But in Belgium, it's actually quite a bit lower. So that's also interesting if you were to make a policy proposal applied to Belgium. So based on this information, you could write a policy proposal that focuses on some specific issues. So try to increase the percentage of people with medical insurance coverage in Belgium, and try to understand why this life expectancy is so much lower than the general population and what the first measures need to be to combat this. So that was just a quick presentation to show you this tool. Yeah, let me know if you have any questions about it. We are planning to work on an evaluation to continue to make this tool more useful for policymakers and people that are trying to influence policy. So also if you have any feedback on the tool and how it could be more useful, I'm also very open to that. Thank you for listening.
Thank you very much, Laura, for reminding us of the importance of having equity at the core of all the work we do. And now we are moving on to our last presentation of this first block that will be led by Inés Nieto from the University King Juan Carlos from Spain. And Inés is going to be talking about something that's really important as well, and it's about how can we measure the impact of the interventions that we implement. So Inés, the stage is yours.
Okay, so well, as they said, my name is Inés Nieto, and I'm a professor at King Juan Carlos University in Madrid. And today I'm going to talk about one of the main lines of research in our research group, that is the social return of investment model. So I'm going to introduce the model to you because I'm not sure if everyone is familiarized with it. And some of the conclusions that we are reaching in our research about this model. So basically, as you know, policymakers need to justify their investment in the different activities and policies. So one of the methods that have been used for this is calculating the return on investment, focused on how much money you get in return of the investment in different activities. But we are working on something beyond this return on investment, that is the SROI, or social return on investment, that takes into account the different social impacts created by the activities or policies. So it's not only that activities create money in return, but also social value. That's why we take into account in this equation the tangible and intangible value for society. So the model aims to calculate not the economic impact, but the social impact, defined as the benefits and costs that are not part of the market system. It was developed by the Roberts Enterprise Development Fund in 1996, and it's been the object of use of many third sector organizations focused on these activities with non-profit. And this tool is really useful because it gives us a theoretical framework to measure the social impact. And then after this quantification of the impact, we are able to translate that into monetary terms, which again is really useful for policymakers because they at the end need to have this number as an argument as to discuss the importance of their activities or the policies they want to implement. There are 6 main stages in the application of this model. So first of all, it's really important to identify the key stakeholders of the different activities so that they are the ones who tell us what's really changing because of the implementation of the policy. Then a theory of change is created with mapping inputs, outputs, and outcomes that I will tell you what each of these components mean. Then these 3 components need to be measured and valued. This is where we most need the data to make these quantifications. And then we make the stage of establishing impact, calculating the final ROI, that is a ratio, and then report the results. Here, as you can see, the social return on investment is mostly led by the Social Value International that you can see in the image. So this is an example or the stages that you need to conduct for this theory of change or the logic model of Fanny's ROI. First of all, as I mentioned, you need to engage with the stakeholders, and the type of questions that you need to address are: who do we have an effect on, who has an effect on us, and how many in each group of stakeholders. So our policy, who is going to be the target of our policy. Then in stage 2, we need to define the inputs, so how much you are investing to implement that policy. The outputs, that's the summary of the activity in numbers. So for example, if you are going to implement a policy to increase the activity levels of the population, you need to quantify that activity. So for example, we are going to implement a program 1 hour per week for the population. And then what changes? So as a result of these activities, what do people experience? An increase in well-being, an increase in mental health, in physical health. That's what the outcomes mean, and that's the main part of the model. And this is where we need to get the data. And how do we do this? By defining some indicators. So how you measure that change in mental health or that change in well-being, for example. Then you need to define for how long this outcome is going to last. So is this physical activity program going to make an impact in 1 week, in a month, in 1 year? And then you need to translate that change in the outcome in monetary terms. This is kind of difficult in some of the outcomes that we are talking about, because I don't know, it's really difficult to say this increase in well-being is equal to, I don't know, £10, for example. So this is a quite challenging stage. This is just an example for you to see how a final ROI model looks like, because at the beginning, if you are not familiarized with it, it seems a little bit abstract. So this is one of the end results that you can find. So this is quite recent report by Sport England, measuring the impact of physical activity and sport in the population in the UK. And they, applying this method, they are able to report this type of results. So, for example, they are able to say that the total primary value of the sport and physical activity is £96.7 billion because of the impact in individual well-being, for example. So what data is needed to conduct this SROI and getting these results? First of all, we need information about the investment in policy, so how much you're going to spend to implement the policy. Second of all, we need quantitative data about the activity promoted, and this is really important to put the focus on monitoring, because many times policies are implemented, but they are not monitored to know the result of that implementation. Then we need to measure the outcomes that are expected from the activity, so the changes that are expected, and this is in collaboration with research, because you actually really need to make this link between your activity and the change that is expected. And also, again, information about the monetary values of those outcomes, and there is also research in this field. This is just a case example for you to see the different steps that are taken in the implementation of the model. So, for example, this is from 2014, when the University of Gloucester site was commissioned by Public Health Administration to evaluate their program as a mean to establishing evidence to whether this program was a good way to using the public funds. So what they did was to create this theory of change, this logic model, explaining how their activities really create social impact or social value. Then they needed to measure those outcomes to have the quantifications. And this is a table showing the result of this work. So, for example, for the pathway of community connections and resources, the outcomes were some examples: improved access to community resources or greater integration. So you really need data on these outcomes. Then education and skills, one outcome would be increased agency or self-awareness. And for the pathway of health and well-being, you would need data on improved mental health, for example. This is the table showing the outcome indicators and corresponding values. So again, really high focus on the quantification to be able to implement the equation that I showed you at the beginning. And the final step is the quantification in monetary terms. And here you can see in the third column the proxy values that are used to monetize each of these different outcomes. What is the real situation regarding the SROI model? So we did a study last year evaluating the social value framing of physical activity in European member state policies. And we found that although this social value framework is present in many of the public health policies in the European Union, the result of the implementation of these policies is not always evaluated. This is related with what I mentioned before about the monitoring. And also, we conducted a systematic review of the social return on investment model applied to physical activity and sport. And one of our conclusions was that there is a high level of variety in the implementation of this model, which makes it really hard and difficult to compare the outcomes of different policies or activities. So we really need to standardize the method. This is why we are working now in an international SROI model applied to physical activity and sport. We are conducting a Delphi study, and with the result of the systematic review and this Delphi, we are planning to publish a paper, a piece of information talking about the limitations and a high focus in the data needs from policymakers to actually be able to implement the model in a reliable way. So this will be a call for action for both policymakers and researchers. So there's some limitations about this method that are needed to be considered. We aim to create a global model, but of course it needs to be contextualized and be adapted to the different cultures. There's always need of supervision of and rationale of what your policy is going to really change, and the difficulty in the quantification of the values that we are talking about. In conclusion, my message to you is that the ROI model is a really attractive and highly useful tool to evaluate health policies, because it gives us information about the social value that we create in the population, but there is a high heterogeneity in the way it is applied, and we need more collaboration between policymakers and researchers to actually get the data that we need. This is just a resource that I found really, really interesting and really useful, a policy guide on social impact measurement for the social and solidarity economy. Also, I leave my contact here for you to ask me any question about this model, our next steps, and follow our future publications on the topic. Thank you.
Thank you very much, Ines. With this presentation, the first block of presentations comes to an end. So we have a bit of time now for questions. And I would like to address the first question to the four of you. It's quite a general question that was posted in the chat, and it reads, what is your experience when engaging with politicians with scientific evidence, given that they are not necessarily looking for the truth or knowledge, but rather to find consensus between different interests? So do they understand the data you present, or how do you work around this? So just any of you can take the question.
Yes, maybe I can answer that. So it's sometimes it is a challenge, because for policymakers, not always understand the different steps that are needed to reach a final result. So we need time, we need resources, we need this data, and it's not always understood, and also the interests are not always the same. But I think it's possible to find a balance. Different projects that we have now with different policymakers, we are actually able to explain them our necessities and also adapt our work to theirs.
Jaisa, you're muted.
Sorry. Thank you very much, Ines, for your answer. I don't know, Miriam, whether you also wanted to answer.
Yeah. Maybe I just want to add something small. So basically, at the moment, I don't have direct experience with interacting directly with politicians. However, this is something that we're going to investigate very soon. So one of the last slides that I presented was about the BPIN project. And there we are really going back to see how this interaction between researchers and policymakers and politicians really took place within the COVID-19 pandemic. And what we could see already finding from the literature was indeed that there was it was not an easy relationship, for multiple reasons, but also when we talk about the COVID-19 crisis, decision had to be made very quickly with the limited evidence that was available, and it was usually evolving evidence. So researchers really had to balance this thing of having to provide, let's say, good enough information, but also in a way that politicians and policymakers would be able to understand it. So let's say simplified presentation, but at the same time, then they were frustrated that the policymakers and politicians were not able to get the more nuanced understanding. So let's say reading the full report. So I think it's definitely a really hard balance, and it's something that we are investigating now to see how we could potentially improve it for this network that we want to create about pandemic intelligence network in time of crisis, but also beyond, because indeed in time of crisis, what changes is the urgency, so the timeline. But this is something that is extremely important in any moment for making sure that evidence-based information reaches the policymakers and the politicians.
Thank you very much. Miriam, we have another question for you. So someone asked, how can you adapt the methodology to overcome different barriers in different emergency situations that involve very different stakeholders, like infectious diseases, natural catastrophes, or the demographic transition? How do you harmonize your methodology or adapt it to different places and different threats?
Yeah, so basically it's not that we adapted based on the barriers, but we adapt the question that we think would be relevant to find those barriers, to really understand how the system works. So our aim is not like we don't want to find barriers, but we will find barriers. So basically we develop a tool that provides us a way to map what is the state of place of that specific information systems that can be on one topic, like we said, infectious diseases, but not only, can be more what we consider One Health, so that we covers also other domains. And basically there we have tailored questions specific to those domains. And this is done, of course, with the support of literatures, because as you can imagine, it's not that we are expert in each and every one of the different systems. So we use the expert that work on this topic to make sure that the question that we ask that are relevant. And then what they are semi-structured interviews. This means that when we go into the room to talk with a different expert, we start with those list of questions, but then we also get guided by the expert on what is really the key issues for their specific topic of expertise. And yes, in that way, even if we don't ask, let's say specifically, what is a barrier in your systems, when the description comes at hand and when we discussed about it, the barriers are merged. So they can, the expert can really point us out to what is not working well, or when we present example of other countries that do it differently, this is a good way for them to understand this could be done better. And this is something that, of course, now we are doing on the topic of pathogens with high pandemic potential, antimicrobial resistance, and CBRN, but that could be done also beyond these three already very broad topics.
Thank you very much. We have a question for Milana as well. Milana, do you have any experience in all the activities that you were discussing before? Do you have any insights on whether you find differences among different patient groups in terms of their concerns and their needs? Because that's something that we often find at EPHA, that especially, for example, when it came to the European Health Data Space, different patient groups positioned very differently, for example, when it came to the secondary use of data based on the specific needs of each patient group. So what's your experience with this?
Thanks a lot for the question. It is indeed like that. I don't think we can have a unified position on such a broad topic. So that's really normal. And as you say, there are differences in the disease area the patients are coming from. It also depends on the sensitivity of the information that's related to their disease, but it can also be related to the country they're coming from, because culturally some societies are more prone to data sharing, some are more data protectionist. So we also have seen this, especially with European Health Data Space, and we're also seeing it with the discussions that we're having on AI. However, what we found is that even though there is not a unified position on what we want specifically from in terms of the rules or in terms of rights that we could have, we have found that the majority of the patients really wants to share the data, and they see the tangible benefits that there is when you share the data, because they see that maybe this can result in either them being cured or someone else, or simply helping the research and innovation. So I think this is still positive. Although in the end, of course, we all have different requirements on how this is done in the end. And what we try to do at EPF is to be as democratic as possible. So we do listen at every single consideration that the patients have, but then we also have to reach a common agreement on how we go forward to the policymakers.
Thank you very much. And then one question for Laura. Laura, what do you think are other key categories that we should be measuring to provide disaggregated data that go beyond the typical age and gender? What are things that people usually forget that you really wish both policymakers and researchers would consider when developing their frameworks?
Well, one that comes to mind is definitely ethnic origin and also handicap. those are two that we've seen also are quite relevant to the health sector. We're currently actually doing a study on racism in the health sector, which is still in progress, but that's a topic that's not enough research, and that's obviously very important. And the same for handicap and other and just physical characteristics and yeah, just disabilities in general. Yeah, we often see that it's more difficult to get good health care for those people. And then additionally, I think what's also really important is to look at intersections. So to look at how, for example, a Black woman might be more difficult, yeah, might have more difficulty getting good care. Or any other intersections. That's often something that's not looked into. But yeah, when gathering data, sometimes this can be quite sensitive. So you have to, of course, get consent. But it would be really useful to continue to look into that.
Thank you very much. So we are running out of time, so I'll conclude with one last question for all of you, but I want you to be super direct and concise. And the question reads, if you were to create one relatively realistic legal or technical rule for data sharing at the European level, what would you create? So just one rule that is relevant from your perspective, the different perspectives that you all bring to the table.
I can start. I mean, we're already doing a European health data space, but if I could just point one thing, interoperability would be mine.
Interoperability.
The first thing that comes to mind for me is self-identification when asking for people's identity, so people can define themselves, how they define their ethnic origin, their disability, or any other characteristic about their life, their lived experience.
So interoperability and identification. I think Miriam also wanted to say something.
Yeah, I wanted to echo the one of Milana for interoperability, because this is something that we see that is a big issue within the countries and across the countries when we talk about being able to share data to a new system. So potentially the Athena platform developed by HERA, this is one of our biggest constraints besides the legal framework to have the permission to share such data.
Thank you very much. And Ines, would you like to add something?
Yeah, well, for me, I think standardization, so that we can really compare between the different countries. If we have the same type of data, it will be really helpful.
Thank you very much to the four of you. And now we're moving on to the second block of this webinar, where we will have Maria Claudia Bodino, team leader for digital innovation policy, working for the European Commission. And she's here to present BDTI, a platform that I hope you'll find very useful if you have been inspired by the previous four presentations. So Maria Claudia, the stage is yours.
Okay, so I was just saying that, there is this idea of creating a single European market for data. And looking at our sector and in general public sector, what we really want to do is to have everything in line with European values and regulation. So in the next slide, you can see a nice summary of the different policy pillars. I try to present in this very compact presentation. You can see all the main important reference we have at the European level in terms of data. So starting from the European Data Strategy from 2020, going from the Open Data Directive, the Data Governance Act, the Data Act, the Interoperable Act, very important for interoperability, and finally the AI Act. I think one very important policy pillar for you working in the health sector is the Data Act, because it's basically defining who can create value from information, from data, and specifically under which conditions. So this is very important in terms of defining a fair environment, and also defining how we can reuse data from different sectors, like health sector, and different realities. So another important point is the definition of this common European data space, where we have the European health data space, that by the way is one of the most advanced, even more because behind the European health data space there is a regulation. So there is it's a binding element that is not present in many other data spaces. So this is very, very important. So when it's about creating value with data, I always like to have this metaphor. It's basically like cooking. You know, you have different ingredients. They are very diverse. They are very with very different granularity, and you need to understand which is your main business question, and also how you want to find your ingredients, how you can clean and prepare them. So basically, how you can connect them. And finally, based on your audience, you know, if it's an academic research, the way you want to analyze and present the findings to your final audience. So it's always like this. The data journey is something, it's something very similar. Then, of course, you can tell me it depends if you're using personal data or maybe aggregated data. These are small different implementation, but that's what we usually like to share with our colleagues and also with our public administration. So let's focus on what we are trying to present today, this big data as infrastructure, that it's a playground for, let's say, implement and also try to develop proof of concept and prototypes in the field of big data. This product is for European public administrations, so it doesn't matter if you are a small or a big public administration. Probably, if you're also working for a public administration and you're an academics, or maybe you're doing your thesis or PhDs together, that's a very good opportunity because you can benefit from this platform for free. You can have this infrastructure free and ready to use in the deploy in the cloud for a duration of 6 months, and you don't need to waste and to let's say invest your time in configuring different tools and different software that you can use to crunch and to analyze your data. So the main objectives of this infrastructure, looking at also at your presentation before, it's really to provide a free playground for public administration experimenting in the data space support center. So in case you have some pilot, you want to develop a proof of concept or a prototype, and this fits under the health European data space, the big data test infrastructure is trying to helping you in order to explore and to prove, you know, your idea before moving maybe to a production environment. And the other important aspect, it's also the fact that leveraging this infrastructure, you can really try to assess the quality of your data, and you can try also to maybe create a feedback quality loop for improving the quality of your data set. This big data test infrastructure is part of the Digital Euro program. In this slide, we just summarize the different areas, and you can see that our infrastructure is under the AI, cloud, and data pillar. Here we have presented all the main different tools we are providing. Probably, if you are a bit, you know, not a data scientist, but maybe you are playing with data, you know most of them. They are completely open source, and they are covering all the main data journey steps that we were mentioning before with, you know, ingredients. So starting from collecting your data and finally to present your information, you can decide between different tools. All of these are already deployed in the infrastructure, and you just need to start the service, and you can immediately implementing your idea and writing your code. One important information is that these tools are also very different in terms of, you know, level of, let's say, if you're not very familiar with maybe writing Python code is not a problem. We have also some visual tools like NIME Analytics, where you don't need to write your code, but you can use something like a Lego. You can drag and drop different building blocks, and you can build your data pipeline. In case you're looking for data, maybe that's not your case, because from my understanding, you already have a lot of information. But there is this amazing hub that is the European data portal, where you can find millions of data sets grouped by different categories. There is the health category, of course, and then you have also the different member states. You can check how many information you have there, and then you can try to experiment in case you don't have a clear idea about your data and which are your main goal for your prototypes. In case you need some inspiration, there is an amazing section in this data.euro.eu, this use cases selection, where you can find many interesting use cases, and you can really understand which is the main challenge they try to solve, and also which are the different tools they try to implement, the data analytics approach, or maybe just the small part of this data, the journey in general. So going a bit more deeper in the big data test infrastructure portal, in this slide we just copy some screenshot of one of the pilot we created with some public administration, and you can see the fact that it's just a basic, let's say, web application. And then once you are there, once you submit your idea, we approve it and we provide you the credential, you can log in the BDTI portal and you can start building dashboards and analytics. In this slide, there are again our tools. They are just clustered by, let's say, functionalities. So based on what you need to do, you have different tools you can decide to experiment, from advanced processing to visualization to data orchestration. Most of them are, I would say not most, but many of them are from Apache. Probably Apache is one of the most interesting foundation about creating software and open source software. Who is BDTI for? European Public Administration. It doesn't matter if you are a small public administration or a big one. And this is the only strong requirement. So the pilot needs to be submitted by a public administration. The second, let's say, important aspect that we need to consider specifically in your case, because you are dealing most of the time with personal data, is that we don't allow the usage of personal data, and we want to have data that are, anonymized or at least aggregated. So in this case, when you want to develop something, we are more than happy to have a partnership with academia, with maybe students, PhD students, and also with GovTech and private companies. This is just another way of summarizing our service. You have a 6 month free of charge. You can test your idea. You can try to extract value and finally create knowledge. And you don't need to care about cost, and you don't need to care about configuration. And this is very important, because this infrastructure is an infrastructure that is already deployed in the cloud. So you can easily leverage the power of Elastic Cloud, and you don't need to, be worried too much about cloud consumptions. After the 6 months, we are going to create an exit package with you, because ideally, for sustainability reason, we would like you moving forward with your initiative. And that's where we try to push for open source development. And also, we help you in moving all the content you create in the infrastructure in your infrastructure. Who use it already? Many pilots we have in the past are from the health sector. So that's why we are presenting this initiative to you today. We have, during COVID, many great examples. One was about text mining. So basically try to create some nice text mining tools to extract information from papers containing many different documents. Then there was another great example that now it's a production environment, is the AUCCP platform. So initially, even if I just mentioned that it's not allowed to use personal data, this was an exception. We were using the big data test infrastructure together with the European Blood Alliance Commission and the national authorities. And we use this in order to speed up the development of a platform for data sharing between member states, about plasma. And nowadays, this platform is still being used. You can also check the website. And the main goal of this platform is to share data for research purposes. So all the information we are collecting in this platform is then shared with member states and specific organizations to analyze and to research on that. Other interesting topics and domains are the mobility, the smart cities one, where cities are using the test infrastructure for analyzing traffic data, time series analysis. And we had also nice and very, very interesting pilots around the topic of e-procurement data. There is one great from Greece and Macedonia, one from Italy, Portugal, and Norway, and then again something around the smart cities and urban data. So now I will give the floor to my colleague Aurora. She will share with you some concrete tools we are offering to our, let's say, public administration when it's about defining the use cases they want to implement, and also about improving their data literacy. Aurora, the floor is yours.
Thank you. So thank you very much. So this, as you can see here, there is the BDTI Canva. The BDTI Canva is really important for public administration to understand and to develop the project, because sometimes they just have the idea, but they don't know how to develop, or like they really don't know how they would like to do things. So this is really important for them to understand, like, for example, the context of the project they would like to do, the objectives, and then like also to understand when they should where they should take the data from, the risk, and also like how they would like to process their data and the data skills they have. So this is really important, like at the very first beginning, to public administration to really get like their mind around the project they would like to do. And it's also important for them when they need to fill the pilot request template, so we can see how to apply for the big data infrastructure. So it's really a simple process. So first of all, we ask you to get familiar with the BDTI service. On our website, we have many resources about this. So we have this presentation, we have like some BDTI essential course. There is like 1 hour webinar where we explain to you how BDTI is working, what it is. So it's really easy for you to get familiar with BDTI. Then, as we have seen before, you can use the BDTI Canva for get your mind around the project. So when you have like the project that is really defined, you can start to submit your pilot request, and you can find easily the document Word in our website. Is really easy to fill. I mean, you don't have to have a lot of like really deep experience in data skill. So like, for example, just to give you a little bit of like background, there is like one section about general information of the public administration that required for you. Then there is a section regarding general information of your project, and another section which is more like on the technical field, but it's like just like for us to understand which application you would like to use from BDTI or from which website you are taking the data from. So these really basic things. Then you send us the pilot request field, and we are going to meet. So just like for understanding better your pilot, if we can give you some advice, and if the pilot project is approved, I mean, like we are going to set up your environment. I mean, like we are not so strict, so normally like the requirement is that they can bring value, the part they would like to do, and it's normally it should be done in 6 months. So we are seeing if it's feasible, and that you have sufficient resources. So when everything's like approved and your environment test is set up, you can start like playing around with BDTI. So BDTI materials, so like for example, presentation and flyer has been translated in all the 24 European languages. This because sometimes like even if like most of the people that think that everyone is able to speak English, sometimes with little public administration, we encounter the problem of like language barriers. So we decide like to translate so everyone can easily understand what BDTI is. now, like actually, we have also this BDTI Kitchen newsletter, and which is really important for us. It's like a monthly newsletter where we communicate to our users, like to our stakeholders, what we are doing. So as you can see, like we have like some space of the data literacy corner where we give you some like news about data. Then we have the BDTI latest news. So just like to tell you what we have done like in the month, the upcoming events, and some spotlight sometimes on public sector initiatives. So what we have also is the BDTI pilot story, which is like an initiative and is really, really important, and also is amazing for public administration, because like when public administration are using BDTI and they finish their project, what we ask them is really to share what they did in with BDTI. Like for example, we have the pilot from Greece, or then like for example the pilot from Norwegian Digitalization Agency. So it's really important. It's also because there is a win-win situation to share your experience, to share your story, also to inspire other public administration that maybe are encountering the same problem and they don't know how to do. So this is really important. Then if we go on the next slide, we can see we have like events, and we had some even in the past with BDTI Skills Studio workshop that we did like for public administration, which are totally for free. And it's for basically improve data skills in public administration. We had like already some workshop. We have one today, so you're still on time like to subscribe. And today we're going to speak about our next climate day classification and predictive analysis for tourism. So it's like predictive analysis with like tourism index, and it's something really interesting. If you missed one of the workshop, you can easily watch like from the link that we put like in the slide. Then we have some more events to come, which I strongly recommend you, like still in November, at the end of November, and other in December. So if you want like to register, you have like the cute QR code on the slide, and you can register for free. So thank you for your attention. If you want like to reaching out to us, you can write on the email that is on the slide, or of course, like we have as well the website. You can also find us in BDTI join our page, and you can subscribe to the newsletter. So if you had any questions, if you have any doubt, you can reach out to us. We are like more than happy to help you.
Thank you, Aurora. Let me just try to summarize. So basically, what we are offering is a free infrastructure in the cloud with all open source tools. And why we are offering this to you? Because probably you have an idea, but you don't have infrastructure in your public administration or in your organization. And this could be a potential win-win for you, but also for the European health data space. So we are part of this European data space offering. In case you want to implement something and you think this is a good fit, feel free to contact us. We are more than happy to provide this infrastructure. Thanks a lot for this opportunity.
Thank you very much, both of you, Maria Claudia and Aurora. And since we are running out of time, I'll only post one of the questions that I received in the chat. And the question reads, is the Commission in touch with national statistic bodies when it comes, for example, to health equality data collection? Thinking, for example, about exchanging data or data collection methods or methods to use, such as data for health policy monitoring. So, yeah, is the Commission in touch with national statistic bodies?
Yes, definitely. Eurostat is part of the Commission, and Eurostat is the one collecting all the national, let's say, data in different domains, not just health. And then beside Eurostat, that is in contact with the national statistical institutes, like for example, ISTAT in Italy and many others, there are also the different agencies that are in contact with them in order to share data.
Well, thank you very much. We had a few more questions, but we don't really have time for it. So you shared your contact information. We'll be reaching out if we need something. I hope everybody found this presentation super useful. I think it was. And that is all for today. Thank you very much for all of you who joined us online. those who contributed questions through the chat, and those who are watching this recording after the event. And special thanks to all our speakers. So bye everyone, and see you next time.
Thank you. Bye-bye. Have a nice rest of the day.
Bye-bye.
Bye-bye.